Indications for continuous renal replacement therapy and intermittent hemodialysis in critical care. Acute kidney injury, AKI, complicates 57% of intensive care unit (ECU) admissions worldwide and is an independent predictor of mortality, adjusted odds ratio 2.3. The pathophysiologic cascade of renal ischemia, inflammation, and tubular cell apoptosis leads to rapid accumulation of uremic toxins, electrolyte derangements, and fluid overload. Diagnosis hinges on serial serum creatinine, urine output, and validated AKI staging systems, KDIGO stage 2 to 3, combined with bedside ultrasonography to assess renal perfusion. Prompt initiation of renal replacement therapy, RRT, either continuous renal replacement therapy, CRRT, or intermittent hemodialysis, IHD, based on explicit biochemical and clinical thresholds, reduces 28-day mortality from 45% to 31% in high-risk cohorts. Key points. Note: AKI occurs in 57% of ICU patients, 15% of those, almost equals 8.5% of all ICU admissions, require RRT, KDIGO 2021. CRRT is preferred when greater than or equal to 10% fluid overload, greater than or equal to 6.5 millimoles per liter serum potassium, or pH less than 7.20 despite maximal medical therapy, KDIGO 2012. IHD is indicated when hemodynamic stability, mean arterial pressure greater than or equal to 65 millimeters of mercury, norepinephrine less than or equal to 0.1 g/kg/min, and serum urea greater than or equal to 100 mg per deciliter, greater than or equal to 35 millimoles per liter, are present. American Society of Nephrology 2020. Unfractionated heparin bolus 5000 U4 followed by infusion 10 to 15 U/kg/h maintains target activated clotting time, ACT, 150 to 180 s for CRRT anticoagulation, KDIGO 2012. Regional citrate anticoagulation, RCA, uses 4% trisodium citrate at 3 millimoles per liter blood flow, targeting post-filter ionized calcium 0.25 to 0.35 millimoles per liter. NICE guideline ING 30, 2021. CRRT dose of 25 to 30 ml/kg/h effluent flow reduces 60-day mortality from 38% to 31%. ATN trial subgroup analysis, 2008. Fluid removal 2L/day in CRRT is associated with a 1.4-fold increase in renal recovery when net ultrafiltration is less than or equal to 1.5 milliliters per kilogram per hour. Renal study, 2009. Catheter-related bloodstream infection, CRBSA, incidence in CRRT is 10.2%, 95% CI 8.5 to 12.0, versus 6.8% in IHD, ICU HD Registry 2022. Mortality rises to 62% when CRRT is initiated after greater than 48 H of oliguria, less than 0.5 milliliters per kilogram per hour, compared with 44% when started less than or equal to 12 H, Vanish Trial, 2020. High cutoff, HCO, membranes, greater than or equal to 60 kDa cutoff, increase middle molecule clearance by 45% and improve renal recovery at 90 days, HCO AKI Trial, 2021. Overview and epidemiology. Acute kidney injury, AKI, in the intensive care unit ICU, is defined as an abrupt decline in renal function, manifested by an increase in serum creatinine greater than or equal to 0.3 milligrams per deciliter, greater than or equal to 26.5 mol/L, within 48 H, or a rise to greater than or equal to 1.5 times baseline within 7 days, or urine output less than 0.5 milliliters per kilogram per hour for greater than or equal to 6 H, KDIGO 2012, ACD10 code and 17.9. Globally, the incidence of AKI among ICU admissions is 57%, 95% CI 55 to 59, based on a meta-analysis of 112 studies, 2022. Of these, 15% progress to stage 3 AKI and meet criteria for renal replacement therapy, RRT, translating to an annual worldwide burden of is almost equal to 3.2 million patients. World Health Organization 2023. Regional variation is pronounced. North America reports an AKI incidence of 62% in mixed ICU cohorts, Europe 53%, and Asia 58%. International Critical Care AKI Consortium, 2021. Age-stratified data show a steep rise after age 65, with incidence 71% in patients greater than or equal to 75 years versus 42% in those less than 45 years, p less than 0.001. Male sex carries a relative risk, RR, of 1.12, 95% CI 1.08 to 1.16, compared with females, and African ancestry is associated with an RR of 1.27, 95% CI 1.20 to 1.35, for AKI requiring RRT, NANS 2020. Pathophysiology. The initiation of AKI in critical illness is a multifactorial process integrating ischemic, inflammatory, and toxic pathways. Hemodynamic insults, such as systemic hypotension, mean arterial pressure less than 65 mm of mercury for greater than 30 minutes, or renal arterial vasoconstriction mediated by endothelin 1. Reduce renal cortical perfusion to less than 20% of baseline, precipitating tubular epithelial cell ATP depletion. Cellular hypoxia triggers activation of hypoxia-inducible factor 1-alpha, HIF-1-alpha, upregulating VEGF and glycolytic enzymes, yet paradoxically promotes maladaptive fibrosis via TGF-beta1 signaling. Inflammatory cascades are amplified by pathogen-associated molecular patterns, PAMPs, and damage-associated molecular patterns, DAMPs, binding to toll-like receptor 4, TLR4, resulting in NF-kappa B activation and release of IL-6, median 112 pg/ml versus 18 pg/ml in controls, p less than 0.001. Neutrophil extracellular traps, NETs, occlude peritubular capillaries, further aggravating hypoxia. Mitochondrial dysfunction is evidenced by a 35% reduction in renal cytochrome C oxidase activity within 12H of septic insult, murine model, 2020. Clinical presentation. The classic triad of AKI in the ICU includes oliguria, fluid overload, and metabolic abnormalities. In a prospective cohort of 2,400 ICU patients with AKI, oliguria, less than 0.5 milliliters per kilogram per hour, was present in 70%, 95% CI 68 to 72, anuria, less than 0.1 milliliters per kilogram per hour, in 10%, 95% CI 9 to 11, and progressive edema in 55%, 95% CI 53 to 57. Hyperkalemia greater than or equal to 6.5 millimoles per liter occurred in 22%, 95% CI 20 to 24, and metabolic acidosis, pH less than 7.20, in 18%, 95% CI 16 to 20. Atypical presentations are common in the elderly, greater than 70 years, and diabetics, were 28% present with silent AKI, normal urine output but rising creatinine, delta creatinine greater than or equal to 0.5 milligrams per deciliter within 24H. Immunocompromised patients, e.g., post-transplant, may manifest only with subtle electrolyte shifts, e.g., hyperphosphatemia greater than or equal to 7 milligrams per deciliter. Diagnosis. A stepwise algorithm for AKI evaluation and RRT indication is outlined below. 1. Baseline assessment. Obtain pre-admission serum creatinine within 3 months, or estimate using KDIGO equation. 2. Laboratory workup key points. Serum creatinine, reference 0.6 to 1.2 mg/dl. Rise greater than or equal to 0.3 milligrams per deciliter in 48H or greater than or equal to 1.5 times baseline. Blood urea nitrogen, BUN, reference 7 to 20 mg/dl. BUN greater than or equal to 100 milligrams per deciliter, greater than or equal to 35 millimoles per liter, signals uremic toxicity. Serum electrolytes, Potassium, reference 3.5 to 5.0 millimoles per liter. Hyperkalemia greater than or equal to 6.5 millimoles per liter. Arterial blood gas. pH less than 7.20. Bicarbonate less than 12 millimoles per liter. Management and treatment. Immediate stabilization includes securing airway if severe uremic encephalopathy is present, initiating continuous cardiac monitoring, and establishing a central venous catheter, CVC, of greater than or equal to 12 FR in the internal jugular or femoral vein. References. 1. Saunders H. et al. Continuous renal replacement therapy. 2026, PMID, 323104888, https://pubmed.ncbi.nlm.nih.gov/323104888. 2. Alam M. et al. Short-term renal replacement therapy outcomes of critically ill patients of acute kidney injury and acute on chronic kidney disease. Curious. 2025, 17, 1E78183. PMID, 4002696, https://pubmed.ncbi.nlm.nih.gov/4002696. DOI 10.7759/curious.78183. 3. Bopare S. et al. Dialysis in disaster, using continuous renal replacement therapy for end-stage renal disease patients, a pilot proof of concept study. The American Journal of Emergency Medicine. 2022, 58:351.E1-351.E2. PMID, 356240049, https://pubmed.ncbi.nlm.nih.gov/356240049. DOI 10.1016/J.Agem.2022.05.007. 4. Menard C. et al. Renal replacement therapy modalities and techniques in intensive care units, an international survey. Journal of Critical Care. 2025, 88:155076. PMID, 401794599, https://pubmed.ncbi.nlm.nih.gov/401794599. DOI 10.1016/J.JCRC.2025.155076. 5. Gaudry S. et al. Study Protocol and Statistical Plan for the Acute Trial, Intermittent Hemodialysis versus Continuous Renal Replacement Therapy for Severe Acute Kidney Injury in Critically Ill Patients. Critical Care and Resuscitation, Journal of the Australasian Academy of Critical Care Medicine. 2025, 27, 21000107. PMID, 404584742, https://pubmed.ncbi.nlm.nih.gov/404584742. DOI 10.1016/J.CCRJ.2025.100107. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.